God bless you all. Thanks a lot for tuning in again. It's a great honor to once again have a discussion with Dr. Daniel Hinshaw. I hope you've been able to catch some of our previous reflections and this edifying series that Dr. Hinshaw has been providing our listeners. Let me make just a short introduction of Dr. Hinshaw for those of you who are just picking up into the series today. Dr. Hinshaw, MD, is an Orthodox Christian layman and a professor emeritus of surgery at the University of Michigan School of Medicine and consultant in palliative medicine at the University of Michigan Geriatric Center in Ann Arbor, Michigan, here in the United States. He's taught palliative care at St. Vladimir's Orthodox Theological Seminary in New York, and he's also taught medical professionals and clergy in international settings, including Ethiopia, Uganda, Serbia, Romania, and Lebanon. For several years, he has served as a visiting professor at Transylvania University in Romania and at the St. John of Damascus Theological Institute and St. George's University Hospital of the University of Balamand in Lebanon. He has published more than 80 papers in scientific journals and numerous books. It's a tremendous blessing to have you, Dr. Hinshaw, speaking with us today on the subject of ethical conflicts at the end of life.
Thank you. Look forward to our discussion. So let me start with an interesting image here and pose some questions. When does life begin? When does it end? I would propose to you that there is a distinction, and this is coming from the anthropology literature, between being physically and socially alive or physically and socially dead. And so even in the various cultures, probably the earliest human response, I guess I would say, to recognizing someone as entering into the converse with the living would be when a mother of an unborn child feels the quickening, feels the baby's movement, approximately around 20 weeks into the pregnancy. And so that moment, even though the child is physically not out of the womb yet, that individual is already starting to develop relationships. And so it becomes socially alive and still is physically unborn. And you can see that the possibility that someone could obviously be physically alive but socially unborn as well. So that, for example, a baby might be evaluated with an ultrasound before the quickening occurs, and that may initiate imaginatively a connection between mother and child, but not in the same way that initial movement, feeling that. And then, of course, at some point, the baby enters the world and is not only physically alive in the generally accepted conventional sense, although from a traditional Christian standpoint, we would say they're alive from the point of conception. But anyway, no one would disagree that a newborn baby is alive and also socially alive. They're now interacting with other people around them and with their environment. And then at some point, as we move along life's trajectory, we could eventually be physically alive, but potentially socially dead. And we talked earlier in one of the earlier sessions about a person with advanced dementia, where there is this sense of the person being socially dead, although I think that I tried to make a case that we can transcend that in various ways. On the other hand, there are situations, and this is particularly true within the tradition of the Orthodox Church, where someone is physically dead, but they're very much socially alive. And we, of course, would immediately recognize that as the communion of the saints. We recognize it practically in our practice of having memorial services after the departure of the soul from the body. And then the thing that we hope is never the case, but I assume, if no more memorial services ever occurred for an individual and they were lost from any kind of collective memory, they might move toward this last state of being socially dead and as well as physically dead. But I wanted to kind of take you through that trajectory just to give you a sense of this fluid state, which of course has existed in a lot of traditional cultures, including the native cultures in America, the Native Americans or Native Canadians of North America, but has been to some major extent in urbanized Western educated people, is a very sharp dichotomy between life and death, because the dead bother the living, and you see we want them out of our presence. And that is an unfortunate phenomenon that has really been more of a recent thing in our culture. Next slide. So, getting now to the practical questions around the ethical conflicts that happen at life's extremes. So, is a biological definition of death entirely satisfactory, such as the cessation of breathing and cardiac function of the heart, versus the brain death criteria that I alluded to earlier? As I said, I think early in the series, I mentioned that the most durable definition of death has been the corruption of the body. And so even Christ makes that point very clearly by waiting until Lazarus is dead 4 days, which by the tradition of the Jewish understanding, the soul has departed from the body, and he's going to smell bad, and his sisters were worried about that when he insisted on opening his tomb. So anyway, that's one issue, and then the other is this utilitarian concern that drives the question: when can we harvest organs for transplantation? And we talked a fair amount about that last time, so I won't go forward, but we can address that a little bit more if necessary as we move along. Next slide, please. I wanted just to bring to attention what the pollsters have often brought up. And I don't think things have changed that much. But in general, if you ask the question about whether abortion, for example, should be legal only under certain circumstances, about half the population are limited, extremely limited pro-choice, and then I'm sorry, I should say, about 50% are pro-choice with some restrictions perhaps, or none, and then about half, or not quite half, are pro-life, would describe themselves as pro-life. The question, of course, how that all parses out in terms of specifics is maybe beyond our discussion right now, but I wanted to emphasize that there's a polarization, as I think we're all aware of, with respect to that issue. And then the other relates to the end of life. And roughly, again, it depends on how the question is asked, but if someone is asked whether, would they favor having the ability to have a physician help them die, about a third would say yes, a third don't know, and a third are vigorously oppose it. And how that is presented, though, is a big question in terms of how it gets played out in the legal definitions. Next slide. So let me present some stories here. I emphasized in the previous talk about the importance of stories. So here we have a 70-year-old woman who's quite pious, and she's experiencing increasing pain in her abdomen from a progressive cancer. She refuses any increase in her pain medication because she's heard that pain medication may shorten her life, and that would be a sin, in her words. Next slide. So this really raises the question of goes back to the medieval scholastics of the doctrine or principle of double effect. And so in its most extreme statement, it would be that a treatment or some kind of intervention, in this case the administration of a strong pain reliever like opioids or morphine in the terminally ill, that is intended to do good and not harm the patient, that is, relieve their pain, is ethically acceptable even if a potential unintended consequence of its administration is to shorten the life of the patient. And if it did, it would be by slowing their breathing. Now, I've practiced palliative medicine for many years now, and the actual, if a person is familiar with, prescribing these medications, the likelihood of this risk is extremely low, because there's a huge safety of margin with most of the agents, especially morphine, between this pain relief on one hand and the slowing of someone's breathing if they cautiously, incrementally dose the medication. So even though we invoke the principle at times to defend it for patients who are concerned, it's really not a big issue for these medications. There are other interventions, though, that we think of all the time where we try to relieve somebody's distress where the risk may be quite a bit higher, but we still take that risk because the person is in great distress. Like a good example of this would be placing a stent, a metal tube that expands to open up an obstructed intestinal tract from a cancer. Those can sometimes perforate the bowel and cause very quick death. But on the other hand, if you don't relieve the obstruction, then the person dies more slowly and with a lot of distress. These are the kinds of situations where this principle is invoked. Next slide. So I think keeping in mind this ethical principle of double effect, we titrate medications then to relieve all the signs of distress, whether somebody's short of breath, they're agitated or grimacing, maybe from pain, before we would remove life support, for example, a situation where a person is clearly dying, the artificial breathing support and so forth is not helping them get better. It's basically prolonging a dying process. In those situations, we cautiously titrate the medications to relieve the distress as we make that change. And if we titrate them cautiously, there's a huge difference ethically from that as opposed to just giving a huge amount of medication and then suddenly causing them to stop breathing. And if someone does the latter, it either means that they don't know what they're doing, and I've seen that, unfortunately, or maybe they did know what they were doing and they were intending to take the person's life out of compassion or whatever the reason might be. But that's a very different act and a very different motivation. Next slide, please. So I wanted to get back to this question about utilitarian ethics, which seems to dominate our secular world. Father John Breck, who has been a noted Orthodox New Testament scholar, but also ethicist, describes the harsh criteria of social utility in which function is placed above being. Quoting him now, the simple fact that one exists is no longer sufficient for that individual to qualify as a person. That individual must be able to think and act rationally and be endowed with the capacity to contribute actively and positively to social life. Otherwise, society has no obligation whatsoever to assume the financial and psychological burdens that a profoundly handicapped person imposes on it. End quote. Next slide. He goes on to say, further about utilitarianism, the sacred character of human life, which God himself invests in the child at its conception, does not in any way depend on the physical or mental health of the individual, nor is it a function of the quality of one's DNA. The dignity of person is bestowed by God, not by human convention. This is why an embryo, like a person in deep coma, is and remains a person in the fullest sense of the term. And of course, it really, our personhood is derived from our relationship with God. And it's really a kind of a horrifying thing to think about how people have divorced themselves from that, so that we have to somehow create a sense of personhood apart from a creator. Next slide. I'll give you another case example. So, although great efforts have been taken to relieve the intense pain experienced by a 35-year-old woman with advanced metastatic cervical cancer, this is a type of cancer that can cause a lot of pain, she continues to suffer intensely. During a visit to her bedside in the hospital, she asks you for help to end my suffering. Now, when somebody makes a statement like this, in this culture, it can raise all sorts of ideas in people's minds. When I present this to doctors in a kind of an open discussion, a lot of them will immediately go, "Oh, well, she wants us to euthanize her, or give her, or show her how to use lethal medications or something." We don't know that. She just says, "Please help me end my suffering." And so we need to actually ask her, "What do you mean?" And sort of listen, let her tell her story. Next slide. So I wanted to just emphasize here that the vast majority, I'll come back to this again later, but the vast majority of physical pain can be relieved with a person conscious. We have a wide array of very good medications to relieve pain from cancer or other causes, especially in people who are near the end of life. In that rare instance where they are in so much distress, and sometimes this isn't necessarily physical distress, or it may be physical distress or I should say psychological or spiritual or social distress presenting as physical distress, where in those rare instances where they're not responding to medication in those conditions, we can do something called palliative sedation. And I usually don't advocate it except for more like a period of respite for somebody who's been sleep deprived because they're in so much distress, where we actually give them medication at a level which will sedate them so they can rest. Now, some people will say, or have done, giving palliative sedation at the very end of life. I think in the instances where I've ever had to actually do that, maybe once or twice, where the pain medication was had to be given to such a degree, or whatever the medications were being used to make them comfortable, that they slept. But it's usually not necessary to do that. And in those situations, when somebody's that close to the end of life, it doesn't accelerate the dying. In fact, it probably gives them more comfort so they can die in the normal kind of trajectory of dying. But if I have my preference, if I'm ordering the medication, I usually do it for a time-limited trial to give the person respite from their distress, and then let them wake up from it a little bit and see where they're at, and also do some detective work with their family, their loved ones, to try to determine what might be an existential problem or a severe spiritual or social or psychological problem that is actually making them quite intense. They're intensifying their suffering. Next slide. But I bring that up because palliative sedation in no way is hastening death. That's not the intention of it. It's to make somebody comfortable enough or relieve their suffering, the physical distress, or perhaps psychological distress, sufficiently so that they can get a breather. But physician-assisted suicide, or I have abbreviated here PAS, or euthanasia, are both interventions that have a clear intent, and that is to cause death. Now, the intention behind it is compassionate, and this is based on the idea that suffering is the ultimate evil, and that all means directed at relieving suffering are legitimate, that they have a moral, for some, the aggressive advocates of these practices would feel that they have a kind of a moral obligation to do this. So in the case of physician-assisted suicide, the physician intentionally provides the means. So in other words, he or she writes a prescription for a lethal medication, and it's the dosing and so forth, and the directions on how to take it. But the patient is the direct proximate cause of their death, so they actually have to take the medication. Euthanasia, on the other hand, is exactly the same thing morally. It's just one step closer, where the physician actually administers the lethal medication. But from an ethical standpoint, they're both the same. The physician has directly caused, in the euthanasia case, and indirectly, but essentially morally, is culpable for either one, for the death. But I think the important point here is that intent is critical, and so people need to very carefully document the care they provide patients at the end of life, what their intent of any intervention they make, so it's not misconstrued or misunderstood. If, for example, someone gives a medication and the person dies soon after receiving the medication, it doesn't necessarily mean that those two things are causally linked together. It's just that temporally they're linked. But obviously it's important to because people die and they come close to their end of their life at some point. And so if the nurse who gives the last dose of some medication that has been giving the patient comfort, comes back 5 minutes after they give the medication, and they're dead, they think, "Oh, did I kill the person?" They did not. Now, the other important point here is that withholding or withdrawing treatment which is no longer beneficial, or administering opioids for the strong pain relievers for pain relief that indirectly hasten death, are not euthanasia. Some people like to try to conflate these things, but they're not. It gets back to intent. Next slide. Now, is there a slippery slope? This, I think, is the challenge for Christians in the postmodern society, and there is absolutely a slippery slope. Next slide. So, physician-assisted suicide quickly was transmuted into physician aid in dying, or medical assistance in dying. These are euphemisms. In fact, euthanasia itself was a euphemism, because euthanasia, literally from the Greek, means good death. These are all things that have been introduced at different points by advocates of these practices. And I think it's really important to not underestimate the power of words. We use euphemisms all the time regarding death. We talk about someone passing away. It's really a problem with children. If you tell a little child who's 4, 5, 6 years old that grandma went to be with Jesus, well, the child may very well ask, okay, well, when are they coming back? So we have to be very careful how we use language. So I think this terminology, of course, attempts to blur the distinction between the Hippocratic prescription. The Hippocratic Oath is very clear about prescribing, it's not acceptable to take the life of a person, and this compassionate care for the dying. And of course, my question to anybody who's an advocate for this is, there have been the Hemlock Society, there have been many groups who have posted online ways you can take your own life, long before these were ever legally accepted for physicians to participate. And so why is it that they want physicians to become executioners? Why do they want to change the essential nature of the medical profession and its identity? So this is I think the question that I've never heard an adequate response from any of my colleagues who advocate these practices. Next slide. So getting back to the slippery slope, I mentioned the euphemisms. The Oregon Death with Dignity Act was the first law that enabled this practice in one of the 50 states of the United States. That's been legal now since 1999, I believe. Washington State followed a few years later, then California, New Mexico, Montana, Vermont, New Jersey, and the District of Columbia. Interestingly enough, they've had trouble getting anybody to want to be a taker in the District of Columbia. And then I think at least one of the provinces or states in Australia has legalized it. And of course, the entire country of Canada, our neighbor to the north, actually my neighbor living in Michigan, immediately to the east, about an hour away, has legalized it across Canada, both euthanasia and physician-assisted suicide. And it's very sad. The Netherlands chief prosecutor for about 20 years agreed to not prosecute anyone if they reported their practice, what they did. And they did, and then eventually it's now been legalized in the Netherlands. I had the occasion as a reviewer of peer-reviewed journal articles about this experience in the Netherlands, though, where people cheated repeatedly. So you were supposed to, and according to the chief prosecutor, the Dutch physician was never to euthanize anybody against their will. But they did. They started to do it in nursing homes because grandma's been there too long, it's too expensive, and there was no informed consent. This was always supposed to be based on informed consent, respecting individual autonomy and so on. So that practice crept in, and there were a number of instances where the medications failed, and they had to do various, sometimes gruesome interventions to make sure they died, so it's not a totally savory practice. And the sad irony of all this is that when the Nazis overwhelmed Europe during World War II, the one group of physicians that refused to participate in the euthanasia laws enacted by Germany were the Dutch physicians. So I don't know why they flipped, but that's very disturbing. Belgium, their neighbor, has gone on to legalize this practice, but they've even gone two steps further. They have legalized taking people who have intractable depression, so serious mental illness that they feel they can't bear to live with anymore. They can ask a physician to take their life. The very thing that one of the major things psychiatry's always been trying to prevent is suicide, and now you get the doctor to do it for you. And then they're even against the advice of the Pediatric Association. There was the physicians that would take care of children in Belgium. They're actually also legalized these practices for minors, for children. Switzerland has, I think, physician-assisted suicide, but not euthanasia, unless they've changed recently. But anyway, there's for sure a slippery slope. But I think the most important thing about the slippery slope is to recognize what it does to, I guess what I'd call a moral numbing. Next slide, please. So I've had very bright undergraduate students that I've taught here at the University of Michigan argue with me about the idea that, well, if it's legal, it must be morally licit, right? Or must be morally right. It's not. I mean, it must be okay, right? I mean, that's if we've enacted a law. Well, I'd challenge any American to remember that for 250 years, chattel slavery was legally allowed in this country. Was that morally right? Did we have several 100,000 Americans die in a civil war because it was, after all, it was just morally acceptable? I mean, this is the kind of madness that we conflate legality with morality. Next slide. So here are some powerful arguments that I would propose against physician-assisted suicide and euthanasia for anyone, but I think they're also relevant as Christians. Next slide. So we can, a lot of the time people ask for help like this, including this patient that I presented. They're really asking for something else. Maybe they have inadequately treated pain or other physical symptoms. They may have untreated clinical depression. They may be expressing a fear of loss of control. We're very a control-oriented culture. They may be fearing being a burden, or they may be in deep spiritual distress. Next slide. We need to ask about these things before we rush to some conclusion. Now, I think in my experience, more like 98+% of distressing symptoms can be controlled with good medications without even thinking about killing somebody. And then at that point, some of them may need to be sedated heavily. Palliative sedation is always an option, which is not the same thing as killing them. Next slide. I think at the end of life, though, is a critical time for growth, even for a secular person who maybe is a thoroughgoing materialist. They still, the we have as human beings a need to reconcile, a need for healing in our relationships. We need to review our life. We need to make sense of our lives and also of our suffering, and its opportunity for spiritual growth. Viktor Frankl speaks very clearly about this. He was a Jewish survivor of the Holocaust through Auschwitz, but he said every moment of life has meaning, and so we shouldn't rob ourselves of the opportunity to explore the meaning that we have in our lives.
That last comment really stirs me up in my pastoral life. I've been greatly concerned about the end of life and its unique spiritual quests that present themselves. I've tried to tease my parishioners as they get into that stage of life to ask them not to do what I call the doctor dance. When you get older and your body is beginning to fail and you're looking at a progression, a managed decline towards death, and you're often retired, right? So you have a lot of time on your hands. It's a huge temptation to fill your calendar with doctor appointments and then to talk about those doctor appointments with your friends and family because you really don't have anything else planned.
Yeah.
Because it's hard to plan when you're old and you're tired and you're uncomfortable and it's hard. You're less motivated to get out of the house. But I really think that is an extremely precious time, not to slow down your spiritual life, but to step up your spiritual life and to not do the doctor dance, but instead invest yourself in your friends and your family and your children and grandchildren, and really find ways that are accommodating to your physical condition, but to refuse to allow medicine and the treatment of your body to become like the thing that guides your calendar and your day. There's a beautiful quote also from St. Basil the Great that I've tried to use to prop up my pastoral argument with my my AT parishioners, and I want to read it and get your response on it. Okay, I think this is just superb, although I don't want to influence you too much to love the quote. But this is what he says. He says, whatever requires an undue amount of thought or trouble or involves a large expenditure of effort and causes our whole life to revolve, as it were, around solicitude for the flesh must be avoided by Christians.
No, it's a wonderful quote. I know the late Tristram Engelhardt, who is an Orthodox ethicist, liked to quote that too. It's very, very appropriate. And I in my stage of life, the only way I can place myself is I feel like I'm the person who was hired at the 11th hour, and I have a lot of work to do. But it's not. I must say, you can see I have a little bandage on my face. I've been acquiring some skin cancers from my youth swimming in swimming pools in Southern California, and too much sunlight. But yeah, I try to not spend all my time with doctors. I've already paid my dues there, working with them as colleagues. But everything you said is right on the mark. No, it seems like
normative. It seems like if we don't act proactively to cultivate our other areas of life that are so precious, that we'll get pressed almost into this mold by our society, into the doctor dance. It's like it's the go-to if you don't have a better alternative. Do you think that's true?
Yeah, no, I think it is, and I think that I think the alternative needs to be warring with the passions, and I have a lot of catching up to do. Yeah. All right. So another thing about obviously we talked about this finding meaning in our suffering and also spiritual growth. Next slide. I think inherently, as I alluded to earlier, that the legalization of these practices has some real questions about safety. Those who have limited or unequal access to healthcare, I think they're more vulnerable to being pressured to do this, either by the societal acceptance of it as normative and the fact that they don't have other means or options. As I mentioned about the dangers of the slippery slope in the Netherlands, where it was being used with non-voluntary euthanasia, I think this is a huge issue. We have large numbers of nursing homes in our country, and they are expensive, and the care of elderly persons is a huge need that is largely met through family caregivers who are also often either having to quit their jobs and move into poverty or do it on top of their work. And so it becomes there's a lot of pressures there. And then, as I mentioned, there have been well-documented failures or problems with the completion that I've seen in papers I've reviewed for the medical journals. Next slide. I think it's an inherent conflict conflict of interest for physicians. Physicians can't be trusted advocates for the life or health of their patients if they also may be the means of terminating that same life. As I mentioned, it's sad, but people have committed suicide throughout recorded history. They have found ways to do this, involving the medical profession and the healing profession, and making killing part of healing, changing the definition fundamentally to what the healing ministry is. You're stepping onto some really dangerous turf, in my view. Now, as I mentioned, with rising healthcare costs, we start to end up with a much more cost-effective program for the end of life. As Medicare becomes too expensive to fund, and all sorts of pressures can be seen. It's certainly directly in conflict with a tradition that goes back even before Christian times with the Hippocratic medicine. And then I think the thing that patients really fear who are seriously ill, and that is being abandoned. And basically, physician-assisted suicide and euthanasia are the ultimate form of abandonment. It's just saying, I don't have anything more to offer you. I can't stand to see you suffer, and so I'm going to end your suffering. And it is incredibly arrogant to do that and to come to that kind of conclusion, that we as human beings have the right to do that by virtue of our training. I mean, in any other circumstances, it would be homicide. So you have to think about how we can suddenly conflate an act that is criminal for any other situation into one that is somehow a healing act. This is something that people don't want to think about. Of course, it also relates to issues about war and execution of criminals. And so, I mean, there are a lot of things here that don't make sense only if you have I guess you can somehow rationalize it because it's all about personal choice. Next slide. So this is my image that I'd like to end this part of this presentation with, and that is from a medieval book of hours from the West, and I always describe it kind of as my image of a interdisciplinary team. So you have the dying gentleman in bed, and you have at least, I think, two monastics there praying, one at the foot of his bed and one near him trying to comfort him. You have the physician in the background, I think, examining his urine. Other people coming in from the neighborhood to visit. And so there's a whole community there participating. The man is not dying alone. The man is surrounded, hopefully, by people who care about him. But he's certainly... His death is not some kind of isolated act. It's part of life. And in this particular context, it's in part of a life infused within Christendom. Thank you.
That's absolutely superb and scary scary, but extremely edifying, Dr. Hinshaw. Thank you so much for carving out time to educate us about where we are and how we can, as Christians, think about these important matters that we're facing in society. Deeply grateful.
Yeah, thank you. I know I want to again express a lot of the people who advocate it in goodwill. I mean, they just, this is the, they're coming from this other perspective. And
Yes.
so I think we have to assume that their intent is actually compassionate. It's just terrifying. It's a terrifying form of compassion. So we have to try to help them understand a different perspective that is infused with centuries of tradition and a worldview that is not bereft of God.
Yes, indeed.
Yeah.
Fear of God is the beginning of all wisdom, even medical wisdom.
Absolutely.
Hey everyone, God bless you. Mark your calendar. June 3rd to 5th, our annual Patristic Nectar conference. You are going to be thrilled at the lineup. Here it is. Holy Orthodoxy, presenting the Christian faith. Go to our website and you can find out there how to participate either in person here with us in Riverside. We hope you'll come, or by live stream if you can't come here yourself. God be with you. Looking forward to seeing you.